Today's topic will be how to interpret chest X-rays. Okay, chest X-rays হচ্ছে we will be talking about the respiratory system chest X-rays today. Okay, this topic is very important and this is also given as a table in the examination. So you need to learn about interpreting chest X-rays. So let's see. This is a typical picture or a radiogram, a skyagram of chest. So what are the structures we are going to see? So this is the trachea, a midline structure, and this one is the aortic knuckle. So what are you seeing? It is a skyagram of the chest. It is a skyagram of the chest or a radiograph of the chest showing two lung fields and a cardiac shadow, as well as we will be describing the structures. Number one, trachea. I will make you learn about how to describe a chest X-ray. These are only the basic structure. This is the first slide. In the subsequent slides, we will be learning about how to describe when you are taking an X-ray plate in your hand in the examination. It is just a basic slide where I have just labeled the normal structures. Trachea, aortic knuckle, this is the right pulmonary artery area and the right hemidiaphragm, retrocardiac descending aorta, left hemidiaphragm, and this is the fundic bubble, and this is the liver. So the main structures which you will have to look in are the lung shadows, the pulmonary area and the cardiac shadow, the cardiac area, as well as you will have to comment on the position, whether the X-ray is in central position, whether there is any rotation in the film, as well as the exposure, whether the exposure is normal. Okay. So what are those terms? Let's see. Number one, the views of the chest X-ray. What do you mean by view? View can be frontal. This one is a frontal view. Okay. So frontal view can be of two types, PA view, posterior-anterior. Okay. PA view কখন বলা হয়? When the X-ray tube is posterior and the plate is anterior to the chest. Understood? Just visualize it. X-ray machine দেখেছো তো? ঠিক আছে? তাহলে that tube is posterior and the plate যেটার উপরে বেবিটাকে we are placing the baby or the child is standing, the plate is behind. Okay. When the X-ray tube is posterior and the plate is anterior, it will be PA, and vice versa. Plate is posterior, X-ray tube is anterior, it will be AP. Okay. There are also some points by which when we are looking at the X-ray plate only, we will be able to say this is PA view or it is AP view. So what are the points? In PA view, clavicles are lying in front of the thorax. So look at this. Look at the clavicles. They are looking like they are lying in the front only. Then behind that the lungs are lying. Okay. So clavicles are lying in front of the thorax. The heart border is clearer and PA view is ideal to see chest pathology or lung pathology. So lungs will be seen more clearly when we are doing a PA view X-ray. So, and what is AP view? When the just ultota, X-ray tube is anterior and the plate is posterior to the chest. Clavicles are not in front, heart border is indistinct and but vertebral shadows are clearer. ঠিক আছে? তাহলে vertebrae, if we want to see the bones, যেটা orthopedic এ তোমরা দেখবে, we write AP. But when we want to see the lungs, the heart, the structures, we do PA view. ঠিক আছে? তাহলে just interpret this. The clavicles appear to be in the front, the heart borders are clear. Okay? Can you see the vertebral column? No, the vertebral column is not so clear. So it is PA view. Understood? Now there is another view called lateral view. Lateral view দেখেছো কখনো? Lateral view X-ray. So lateral view is, why is it done? Because we want to see the mediastinum. Just remember the anatomy of the mediastinum. Most of the pictures in anatomy book were in lateral view. So we can see the superior part, the middle part, the lower part, okay, right side, alada kore, left side, erakom. So we want to see any lymph node enlargement. We want to see thymus, or whether there is a mass in the mediastinum, or we want to see a particular lobe. When do we want to see lymph node enlargement? Suppose we are suspecting the patient is having tuberculosis and there are big hilar lymph nodes. So if we want to look at the lymph nodes more clearly, we can do lateral X-ray. Suppose we are suspecting there is leukemia or there is lymphoma, okay, there will be enlargement of lymph nodes. If we suspect that the child is having thymoma, thymus will be enlarged, okay. If when we are suspecting any mediastinal mass like in T-cell leukemia, in lymphomas, we can do the lateral view X-ray and we will be able to see whether there is any mediastinal mass, okay. And lobar pathology, suppose in PA view X-ray, you are saying there is a huge consolidation in the left lung. So if we do a lateral view, we will be able to appreciate the consolidation and the expanse of the consolidation more clearly. Because at that point of time, we are not seeing only the frontal side, we are seeing the lateral side as well. তাহলে আমি এটা বুঝতে পারবো যে লাংয়ের কতটা ওই কনসলিডেশনে ইনভলভড হয়েছে, হোয়াট ইজ দ্য ডেপথ, হোয়াট ইজ দ্য এক্সটেন্ট। তার থেকে বেটার সিটি স্ক্যান, কিন্তু এক্স-রের ক্ষেত্রে দুটোই ভালো ভিউ। তো ইট ডিপেন্ডস অন হোয়াট ইউ ওয়ান্ট টু সি, অ্যাকর্ডিং টু দ্যাট ইউ আর চেঞ্জিং দ্য মোডস, changing the views. যেমনি আমরা when we are trying to click a photograph from our phone, we use different modes. So it's according to our will that I want to see this view, okay. Now we come to exposure. তাহলে প্রথমে কি পড়লাম আমরা? View. তাহলে মানে in the end of the class you will be able to describe a chest X-ray point by point. So first is view, second is appropriate exposure. So what do you mean by appropriate exposure? Vertebral spine is visible through heart shadow. In the first X-ray you couldn't see the vertebral shadow. So exposure ta arektu bhalo hote parto, mane motamoti I should get an idea that there is a vertebral column behind, okay. So vertebral spine is visible through the heart shadow. Lung markings are visible up to the periphery. Lung markings যেগুলো হয়, you know about the lung markings, they should be the bronchovascular markings. যত prominent দেখবে মানে exposure is good, okay. Lung markings are visible up to periphery. There are some pathological conditions also when the bronchovascular markings are prominent, like in bronchopneumonia, like in any reactive airway disease or in viral pneumonia. You know, the bronchovascular markings will be prominent, but those are pathological. But physiological also, if we are getting to see the prominent normal bronchovascular markings, means the exposure is good, okay. Then when will you got underexposure? Underexposed X-ray will be more white. প্রথমটা একটু বেশি white ছিল, more white, and the vertebral shadow is not seen at all. But overexposure means the film will be more black and vascular markings are not seen in periphery. Understood? So more white is bad also. There are some pathological conditions like consolidation, collapse, you will get white. But generally structures are normal, but the film is more whitish. It is usually underexposed. And if it is more black is overexposed. But you can get black in pneumothorax also. You can get black in hyperinflated. But when you are seeing no, the structures are all okay, but the film is more blackish, it means it is a bit overexposed, okay. Now position. What is central position? Central position is when examiner will ask you, okay, just tell me how will you determine the position of the film. So what is the structure you will look at? The medial end of clavicle. Then whether the medial end of clavicles are equidistant from the midline. and the anterior end of the ribs, whether they are equidistant from the same side, pedicles. Pedicles কোথায় থাকে? vertebral column এ, ঠিক আছে? তাহলে let's see. So position দেখো, medial end of the clavicle আর midline এর মধ্যে equidistant আছে কিনা. If this is the midline and this is the medial end of the clavicle, এই ডিস্টেন্সটা এখানে equidistant নেই। Here this side the distance is a little bit more, right? So তার একটু slight rotation আছে, not central. And anterior end of the rib, which one are the anterior? এইগুলো anterior end, যেটা prominent সেটা usually posterior ribs গুলো বেশি prominent দেখা যায়। anterior end কোনগুলো বল? সামনে দিকে এরকম করে আসছে, এরকম করে আসছে, এরকম করে আসছে, তাহলে anterior end of the ribs এর মাথাটা midline থেকে, ঠিক আছে? ক্লিয়ার? ওকে, now we will talk about the structures. What structures you will see? The bony cage, the soft tissues, the diaphragm, mediastinum, that is superior mediastinum is seen in posterior-anterior view, and if you are seeing a lateral view x-ray, anterior, posterior, superior mediastinum. Now you will have to appreciate the cardiac shadow also. What is the size of the cardiac shadow? What is the shape of the cardiac shadow? What is the position of the cardiac shadow? Okay, and also you will have to describe the lungs and the pleura as well. So let's see, how will you describe the bony cage and the soft tissue? You will have to see whether there is any soft tissue swelling. Okay, skin er opor kono swelling dekhle you will have to say whether there is any intercostal chest drain in situ. ধর একটা এমপাইমা ছিল, চেস্ট ড্রেন দেওয়া আছে, তুমি দেখতে পাচ্ছ, if you don't talk about it, if you don't mention it during exam, it is a negative point because it is very obvious that a chest drain is in situ. Then whether there is subcutaneous emphysema. Subcutaneous emphysema কি? Collection of air in the subcutaneous tissue. কখন হতে পারে? ট্রমা, চেস্ট ড্রেন দেওয়ার সময় একটু হাওয়া ঢুকে গেল চামড়ার তলায়, বা এটা ট্রমা হলেও হতে পারে, ঠিক আছে? নিউমোথোরাক্সে হতে পারে। তারপরে you will have to look at the counts of the ribs, whether the normal rib count or there is cervical rib or absent rib. cervical rib কি ছিল মনে আছে? অ্যানাটমি তো পড়েছো? হ্যাঁ, যদি একটা এক্সট্রা রিব ওখানে থাকে, ঠিক আছে? rachitic rosary কি হয় বলো? what is rachitic rosary? কি হয় সেটা? rickets এ হয়, but what are the মানে what is the structural problem? rosary beads দেখবে, পড়ে দেখবে আজকে ক্লাস হয়ে গেলে, what do you mean by rosary? ঠিক আছে, rosary কি পড়ে দেখবি, ইন্টারেস্টিং। এবারে you will have to look at the structure of the spatula, whether it is wide, thick, rib structure. There are some we are talking about some abnormal shapes and structure of the ribs. There is a condition called mucopolysaccharidosis. It is a metabolic disorder. What happens there? The ribs are abnormal in shape, they just look like white thick spatula. এই ছবিটা you can see the picture in bedside clinics by Dr. Shivarjun Ghosh. Just go at after the class, when you return to the hostel, just open the book. In this X-ray chapter only you will get to see the picture. White thick spatular ribs in mucopolysaccharidosis. Okay, then chalk white bone. Okay, chalk white bone density will be found in osteopetrosis, or it is also called bone inside bone appearance. Okay, then punched out radiolucencies are found in histiocytosis X or Langerhans histiocytosis, মানে বোনগুলো থেকে পাঞ্চড আউট হয়ে গেছে, কালো কালো জায়গা, মানে বোনগুলো লাইটিক লিজনসে ভর্তি, ঠিক আছে? যে পয়েন্টটা বুঝবি না, প্লিজ আস্ক কোয়েশ্চেন্স। Now we will appreciate the diaphragm. Diaphragm এ কি? We will have to look for both the domes of the diaphragm, and this is a misprint, not domestic, both the domes of the diaphragm. Then normally the right dome is higher than the left dome. Okay, In mid-inspiration, the domes are at the level of the fourth and fifth rib, fourth to fifth rib level. In full inspiration, they will go one space lower, and in full expiration, they will come one space higher. Eventration. What is eventration? Can anyone tell me? It is a defect of the diaphragm. The diaphragm ekta erokom triangular elevation moto hoye jay. Again, go to the hostel and look in the book. There is a picture. What is eventration? It is a congenital deformity of diaphragm. Remember it. What is CDH? Congenital diaphragmatic hernia. Can anyone tell me? So, the contents of the gut, they will come into the thorax. You know about Bogda Lake hernia, Morgagni, foramen of Morgagni, na rokom hernia ache. So, congenital diaphragmatic hernia. Then there is another condition called tethered diaphragm. Means diaphragm er je shape ta ache, there is some structure, jar jonno diaphragm ta ekta jaygaয় উঁচু হয়ে আছে. মানে the structure is not normal. Then we come to mediastinal shadow. We will look at whether there is any lymph node enlargement, thymus in infants. Thymus to infants এর থাকে, যত বড় হয় আস্তে আস্তে the thymus will disappear, it will regress. Then look at any mass in the mediastinum like lymphoma, neuroblastoma, teratoma. Then they will be seen in both P and lateral views. Then we will appreciate the cardiac shadow. There will be a separate class on cardiac X-rays. This is just a basic thing. Left border, how is this will again be repeated in the cardiac X-ray class. But just you will have to learn by heart. Examiner will ask, tell me the structures which are making the left border of the heart. Tell me the structures which are making the right border of the heart. Okay. So left border is formed by aortic knuckle, that is knob-like convex, pulmonary trunk and its left branches small bay, left ventricle forming the major part of left border, and right border superior vena cava, ascending aorta and right atrium most. I will show it to you. Just look at it. Left border eta bolechilam na aortic knuckle. Pulmonary bay ta ekhane hoy, tar tole pulmonary bay, then you are getting to see the left ventricle. Right heart দেখো উপরটা পুরো superior vena cava is there. তলাটা right atrium. মধ্যখানে ascending aorta, a small portion is there. Okay. Again, look at the diaphragm, the right dome of the diaphragm. Look at the diaphragm, left dome of the diaphragm. Right dome is higher. Okay. Again, is there any deformity? There is no defect, no herniation, no tethered, no eventation. এরকম করে একটা খোঁচার মতো হয়ে যায়, triangle মতন. You can see the continuity of the diaphragm is not maintained. So when you are looking at the X-ray, you will have to see whether the border is continuous or not. Okay. Then again, cardiac shadow holo, diaphragm holo, you are seeing the mediastinum also. Here the thymus is not there. It is an older child. Okay. Thymus is not there. You can look at the soft tissue also. Soft tissue, there is no. So we will talk about the lungs, the main thing. So lungs ki on PA view and lateral view, when we are interpreting lungs, when we are interpreting any lung pathology, we will have to look at three things. Number one, position of the mediastinum. Number two, lung fields itself. And number three, lymph nodes or other mass in the mediastinum. So how will you comment on position of the mediastinum? How? Position of tracheal air shadow. Normally it is on the midline or slightly to the right. Midline is decided by the vertebral shadow and equidistant from medial end of clavicles, and second is position of cardiac shadow. There is a term mediastinal shift to the right, to the left, push, pull. These basic things you know. So how will you determine on the basis of what you are saying that there is push or pull? So you have to know about the normal thing also. So normal thing hoche eta. Tracheal shadow is midline or slightly to the right, and position of the cardiac shadow. ঠিক আছে? So look at this again in the beginning. Trachea is almost in the midline and slightly to the right also you can say. Yes, and again cardiac shadow is normal in position. Fields. Now we will describe the lung fields. Number one, normal. Normal lung fields means what? Normal translucency with normal bronchovascular markings. Now we will talk about the abnormal condition. Number one is hyperlucency. Hyperlucency means more air, more black. Okay. So hyperlucency. In case of hyperlucency, if there is presence of lung markings, then if it is bilateral hyperinflated, it is because of bronchial asthma, bronchiolitis, and there is no mediastinal shift. If it is unilateral, দুটো দিকেই তো hyperinflated, mediastinal shift হবে কি করে? বুঝছো তো? But if it is unilateral hyperinflated lung, we will call it compensatory emphysema and there is no mediastinal shift. And obstructive emphysema if there is mediastinal shift to opposite side. গুলিয়ে গেছে কিছু জায়গাটা আমি বুঝতে পারছি, তোমাদের কি করে বুঝবে দেখো। If both the lung fields are black, hyperlucent, then it is because of some condition which is causing air trapping in both the lungs. What are those conditions? Bronchial asthma, bronchiolitis. Since both the lungs are big and hyperlucent, there will be no mediastinal shift because it is a bilateral pathology. But if a single lung is affected, a single lung is hyperlucent, but there is no mediastinal shift, it is compensatory emphysema. Just remember in pathology classes or medicine classes, you will be having them. They will take classes on emphysema. Emphysema are of two types, obstructive and compensatory. Compensatory কখন হয়? When the other lung is pathological, the other lung is having collapse or the other lung is obstructed, another lung is compensating by having more and more ventilation. So it is becoming, there is air trapping in that lung. But in that case, there will be no mediastinal shift. But if it is obstructive emphysema, the pathological one, the COPD one, then there will be mediastinal shift to the opposite side. Okay? Now, but in those cases, lung markings will be present. But if you see there is hyperlucency, but there is no lung markings, that means what? Lung has collapsed. That's why I am not able to see any lung marking. I am only seeing black. So what are those conditions? Pneumothorax, pneumatocoel, lung abscess cavity. The abscess cavity can be empty or it can have a fluid level. Understood? Because inside the pneumothorax there is no lung tissue. Lung ta to collapse kore side e chole geche, tai na? And pneumatocoel and lung abscess cavity. Now we will talk about pneumothorax X-ray. Hyperlucent area, I will show you the pictures, don't worry. An hyperlucent area without any lung markings, collapsed lung will be seen as an opaque globular mass and having a sharp margin at the hilum in tension pneumothorax. Mediastinal shift to the opposite side in tension pneumothorax. So look at this X-ray. Just describe it. This is an having a sharp margin. This is an opacity. This is the collapsed lung. And this is the pneumothorax. Here also some amount of pneumothorax is present. Look at this. This is the lung margin. এই অবধি lung markings আছে, এখানেও আছে, but এখানে কোনো lung marking পাচ্ছ black area তে? No. So this is pneumothorax. Is there mediastinal shift? Tell me. ভালো করে দেখো। কি কি দেখছো? কোন কোন প্যারামিটার? Which parameters you will see to describe about mediastinal shift? Position of trachea. শিফট করেছে, একটু বেশি রাইটে চলে গেছে, দেখো অতটা কিন্তু বেশি সেন্ট্রালে নেই, তাহলে এই দিকটা ঠেলছে। আর হার্টটা, কার্ডিয়াক শ্যাডোটা অতটা ডিসপ্লেস হয়নি এখনো, বাট স্টিল there are signs of a little bit of mediastinal displacement is there because the amount of pneumothorax in the left side is more. So I want a volunteer. I have talked about all the points. Now you will have to tell me how will you describe this X-ray. In the examination and in the examination hall, when you will be given this X-ray, you can't just simply tell this is pneumothorax. Describe it. যে কেউ volunteer করে just describe the X-ray. তারপরে আমি বলে দেব। এনিওয়ান, তুই বল, জাস্ট ট্রাই কেমন করে ডিসক্রাইব করবি।
This is a diagram of chest of a cyan.
Okay, what is the view?
The view is it's a PA view.
Okay, so view. Okay, what is the position?
Position sitting supine.
No, no, position বললাম না, midline নাকি rotation আছে বলো। So you'll have to see medial ends of the clavicle. Look at them. Is it central position or it is rotated?
Central position.
Okay, তাহলে দুটো পয়েন্ট হয়ে গেল। এইভাবে কিন্তু সাজিয়ে বলতে হবে। First, it is a sciagram of the chest with PA view with central position. Then tell me about the exposure. It is black, but this black is not normal.
The vertical column is can be seen through the cardiac shadow.
It is proper exposure. You can also see the lung field এর যতটা তুমি দেখতে পাচ্ছ, you can see the lung markings almost up to the periphery. It's proper exposure. Then তিনটে পয়েন্ট হলো। Then you tell me about the skin and the soft tissue structures and the bones. First point, it was that.
No deformities in the bone and soft tissue to মানে কিছু নেই।
Okay. Then talk about the diaphragm. Diaphragm is normal in structure. যদি তুমি কিছু, if you see anything abnormal, you will have to describe it. Just look at the diaphragm dome, whether they are continuous, whether there is a breach. You can see the fundic gas bubble very clearly. এই যে এটা, এটা তো very good observation. This is pneumothorax এর এয়ারটাই নিচে গেছে। ঠিক আছে, ঠিক আছে, তারপর বলো এবারে। Now describe the lung, both lungs, what you can see. How will you describe these areas?
On the left side there is hyperlucency around the periphery of the chest, and the lung has collapsed and air is present between lung and the rib cage.
Acha, right side?
Right side there is also some amount of air is present in the osteopenic angle. And
okay, the lung এর ক্ষেত্রে ফার্স্টে we talked about lung fields, then position of the mediastinum. Describe the position of the mediastinum.
The mediastinum is shifted towards right.
Slightly shifted to the right. Okay.
And the trachea is deviated towards the left.
Okay, ঠিক আছে। Do you want to comment on the heart cardiac shadow? So এই যে ডিসক্রাইবটাও করলো, ভেরি কোয়াইট নাইস। ঠিক আছে, এটাকে একটুখানি মানে পলিশ করতে হবে বলতে বলতে। তো এই পুরোটা আফটার গিভিং দিস এন্টায়ার ডেসক্রিপশন, লাস্টে ইট ইজ মোস্ট প্রবাবলি an X-ray of bilateral pneumothorax, left side more than right side. Bas. So this is a sciagram of chest, PA view and proper exposure and normal skin and soft tissues and bones, and we can see the diaphragms are also normal in structure. We can see there is hyperlucent area in the left lung field as well as in the right lung field, more in the left lung field, and we can see an opaque shadow denote with a sharp margin denoting the collapsed lung on the left side, as well as on the right side also I am able to see lung with air hyperlucent area in the right costophrenic area. Okay, so most probably, and there is slight shift of the mediastinum to the right side. The cardiac shadow seems normal, so most probably this is an X-ray of pneumothorax, left side more than right side. ব্যাস, আর তোমাকে কিছু জিজ্ঞেস করবে না। যতটুকু নম্বর এক্সরেতে আছে, যদি তুমি প্রথম the first X-ray you are given, if you describe it, because examiner will see the effort, whether you are trying to describe each and every point, you will get full marks. Okay, sit down. Okay, mediastinum shift dekhte gele two things you will have to see. Let's go back to the slide. So position of mediastinum is seen by tracheal air shadow, or normally it is on the midline or slightly to the right. Midline is decided by vertebral shadow and equidistant from the medial end of clavicle. আরেকটা হচ্ছে position of cardiac shadow. তাহলে এইখানে এই এক্সরেতে তুমি position of mediastinum কি করে দেখছো? Number 1 is the tracheal air shadow. Whether it is central, equidistant from the medial end of the clavicle, right এর দিকে একটু বেশি গেছে বলে নরমালিও রাইট এর দিকে একটু বেশি থাকে, বাট জাস্ট লুক এট দ্য এক্সরে, দেয়ার ইজ নিউমোথোরাক্স, সো লেফটে একটু বেশি পুশ করছে একটু। And also if you see that the heart is shifted to the right or to the left, you will comment on the mediastinal shift. Clear হয়েছে তো? ঠিক আছে। Now we talk about the obstructive emphysema. Obstructive emphysema তে কি বলেছিলাম? Hyperlucent lung and hyperinflated lung with presence of lung markings. Okay, mediastinal shift to the opposite side if there is considerable hyperinflation. Understood? এবারে let's look at it. এই যে এতটা বড় লাং কতটা শিফট করেছে দেখো, হার্টটা তো পুরো ওই দিকেই চলে গেছে, রোটেট করে গেছে। The lung is totally rotated. Okay, okay, I want someone to describe it. It's a bit difficult x-ray, এতটা একটু ডিফিকাল্টি লেভেলটা একটু বেশি, কারণ এটা মনে হতে পারে যে লেফট দিকটা রাইট দিকটা পুরোটা কোলাপস করে গেছে। even if in the examination hall you call it pneumothorax, or even in the examination hall you call it pneumothorax plus collapse of right lung, you will get some marks. It's a little bit difficult x-ray. Okay, so here just whenever you are getting a difficult x-ray, just start from the basics. Okay, তুই volunteer, just যে পয়েন্টস গুলো বলেছিলাম এই পয়েন্টস অনুযায়ী। আচ্ছা, whenever default এটা মনে রাখবি, whenever you are given to describe a chest x-ray, call it PA. পরীক্ষার সময় কোনো অ্যানালাইসিসে যাবি না, call it PA. অর্থোপেডিকের এক্সরে গুলো যখন দেখাবে এপি। whenever you are given to describe a chest x-ray, when you are interpreting the lungs and the heart, call it PA by default. Okay, so okay, view then হার্টটাও তো শিফট হয়েছে দেখ, so there is mediastinal shift to the right. Okay, there is a huge translucency, huge hypertranslucency in the হ্যাঁ এই ফিল্মটা একটু এরর আছে, এমনিতেও পজিশনটা ঠিক নেই, ঠিক আছে, পজিশনটা ঠিক নেই, রোটেটেড হয়ে গেছে, প্লাস ওই অতটা বড় যে হাইপার ইনফ্লেশন অন দ্য লেফট সাইড, ইট হ্যাজ অলসো পুশড দ্য হার্ট, পুরো এমনি করে রোটেট করে গেছে। হয়তো এতটা মনে হতো না, ঠিক আছে, না মানে কি বলতো সেন্ট্রাল নেই, একটু বেঁকে গেছে, হ্যাঁ রোটেট করে মানে একটু ঘুরেও যায়। কার্ডিয়াক শ্যাডোটা ভাব না, কার্ডিয়াক শ্যাডো ইজ লাইক দিস, ইট ক্যান বিকাম দিস, এরকম পেছনে চলে যায়, বিকজ দ্য লাং ইজ পুশিং বা লাং ইজ পুলিং। ওকে, there is a torsion force over the heart, it is pulling, it is pushing. Okay, now in hyperinflation, lung field will be hyperlucent, the wide open costophrenic angles, flattening of the dome of the diaphragm and widening of intercostal space. So in hyperinflation, what will happen? Lung field will have more air, so it will be hyperlucent, the costophrenic angles will be wide open, there will be flattening of the domes of the diaphragm, and there will be widening of the intercostal spaces. Clear? Now we will talk about the opacities on lung. আচ্ছা এটাতেই বলি, hyperinflation. hyperinflation টা এখানে একটু difficult to, because there is flattening of the dome of the diaphragm. This side is a bit flattened and there is also widening of the costophrenic angle. You can't see the intercostal spaces, therefore I cannot comment on them. Okay, but there is translucency. Okay, now we will talk about the opacities on lung area. So opacities in the lung field means white areas. Opacities in the lung fields are due to consolidation, collapse with consolidation, fibrosis because of tuberculosis, bronchiectasis, pleural effusion or empyema, hydatid cyst. Then we have the miliary mottling, okay, because of tuberculosis, because of tropical pulmonary eosinophilia. What is consolidation? Consolidation appears like a dense homogeneous opacity. The location depends on the area of involvement. It can be lobar, segmental, subsegmental, where it looks patchy. There will be no mediastinal shifting and costophrenic angles will be clear. So this is a consolidation. Who will describe? We got to go. Describe. Just describe the X-ray. Basic points. Okay. Well. Okay. AP লেখা আছে, call it PA view. ঠিক আছে, PA view. Then সব সাদা লাগছে, তাহলে কি? Underexposed. Then the position, ট্রেকিয়াটা তো আমার মিড লাইনেই মনে হচ্ছে নর্মাল, ঠিক আছে। দেন হ্যাঁ সেটা একটু আছে না, এটাকে ওটা গ্রস রোটেশন ইউ ওন্ট কমেন্ট, ঠিক আছে, মোটামুটি নর্মাল বলতে পারো। আমি মানছি তোর পয়েন্টটা তুই ঠিক বলছিস যে এইদিকে ক্লাভিকেলের মিডিয়াল এন্ড থেকে হয়তো ডিস্টেন্সটা একটু পুরো ইকুয়াল হবে না, a little bit difference is there, ঠিক আছে। Then just talk about, then describe the domes of the diaphragm. Normal. Skin and subcutaneous tissue and bones, any abnormality? No abnormality. Describe what you are getting in the lung. Describe the problem, describe the pathology. Dense homogeneous opacity, এইটা বলতে হবে। DHO, you are getting a dense homogeneous opacity in the right upper and middle zone of the lung. Okay, and it has sharp margins also. It is lobar consolidation. Okay, so you are getting a dense homogeneous opacity in the upper and the middle zones of the lung, and there is no mediastinal shift. The costophrenic angles are clear. It is mainly due to consolidation. Mostly it is the consolidation of the lung. And what is the cause? Pneumonia, lobar pneumonia mostly. Okay. Actually, anatomically দেখলে কিন্তু lower portion of the upper and some amount of the middle lobe is involved. ঠিক আছে, পুরো টোটালি তুই আপার বলতে পারবি না। আর when you will be learning about the respiratory system clinics, you will learn that the lung is divided into some zones, upper zone, middle zone, lower zones. তো জোনের একটা টোপোগ্রাফি আছে। তুই practical just go to the hostel and just open the respiratory system chapter from Bedside Clinics book. You will see lung has some topographical markings. That's why in the X-ray we talk about zones. When we are doing percussion, when we are doing that inspection, palpation, percussion, auscultation, we describe the finding in the terms of zones. So you will have to also remember the topographical markings. Okay? এইটা তো হ্যাঁ বলতে পারো actually some ECG leads are attached, some electrodes or leads are attached on the skin ঠিক আছে okay let's see what is collapse. So collapse can be absorption collapse. So it is seen as a homogeneous dense opacity with sharp margins. Okay. Location depends on the location of the blocked bronchus. So again collapse can be lobar, segmental, subsegmental. Area of the opacity is smaller than the normal radiological area of the portion of the lung involved. কি হচ্ছে collapse কি হচ্ছে চুপসে গেল, it is getting collapsed. So when air will enter এরিয়াটা বেড়ে যাবে, বাট যখন কোলাপস হচ্ছে এরিয়াটা ছোট, তাই জন্যই এই লাইনটা the opaque area of the opacity is smaller than the normal radiological area of the portion of the lung involved. Can you appreciate it? Normally the lung is aerated, it is normal, but when it is collapsing it is becoming small, contracted. So we can see only this much of opacity, but when it will become normal the area will be bigger. Collapse এর এরিয়াটা ছোট লাগবে, দেখ ওটাই বলা হয়েছে নরমাল এটা. The opacity will correspond to the collapsed lung tissue around the site of the block or towards the hilum. Why collapse happens? If there is a block of the bronchus, that portion of the lung which is getting supplied by the bronchus will collapse. Suppose a foreign body is entering into the bronchus, or then it is going into a bronchiole, the bronchopulmonary segment will collapse because it is not getting into any air. That is called absorption collapse. Okay. If collapse is large, there will be mediastinal shift to the same side because collapse pools. Okay. So you can see this is collapse. পুরো একটা হেমিথোরাক্স কোলাপস হয়ে আছে. ডিসক্রাইব করবি, কে কর? তুই কর. Okay. Okay, almost I can agree. Don't look at the trachea. Medial end of clavicle. Okay, then. Left side is not visible, but the right side appears normal. যা দেখছো তাই বলবে. Then, collapse কথাটা প্রথমে বলবে, you will have to describe it. Okay, skin and subcutaneous tissue appears normal. Bones, the ribs appear normal. Now you are seeing again DHO. There is a dense homogeneous opacity. এবার বলো. And there is what about the mediastinal shift? Yes. Why? Because you can see the pool of the trachea. Trachea is pulled to the left side. Can you see the heart? But is there any shift of the heart? Yes. হার্টের যে পোরশনটা নরমালি দেখতে পাচ্ছিলিস, রাইটে কিছু দেখতে পাচ্ছিস? গোটাটাই লেফটে চলে গেছে. So there is total mediastinal shift. The trachea as well as the lungs. Heart. Understood? Pool হয়ে যায়. Understood? তাহলে so most probably this is a collapse of the left lung. Total left lung has got collapsed. হ্যাঁ, এই যে এইটা দেখ ট্রেকিয়া, জাস্ট ট্রেস ইট. এইটা দেখ ব্রঙ্কাসটা ভাগ হয়েছে, দেখ রাইট ব্রঙ্কাস, লেফট ব্রঙ্কাস, and this is the trachea. এই দেখ, I am tracing it from above. Trachea, 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 trachea. This is the carina. Right bronchus, left bronchus. Understood? Left. So trachea has got pulled to the left and you cannot see heart at all. It is totally on the left side. Understood? Okay. Now we will talk about pleural effusion or empyema. Okay? Okay. যেটা বুঝবি না বল, কোনটা বুঝিসনি দেখা, কোনটা বল, কি এইটা বলছিস? না, এটা কি করে হার্ট হবে? হার্টের ভেতরে এটা লাং এর মার্কিং, হার্টের মধ্যে এরকম কালো দেখেছিস? ঠিক আছে, these are the bronchovascular markings. Okay. Now we will talk about pleural effusion or empyema. Pleural effusion means what? Fluid collection in the pleural space. And what is empyema? There is pus collection in the pleural space or pleural cavity. So pleural effusion, on the side of the effusion again you will get homogeneous opacity. Opacity is maximum over the inferolateral area of the hemithorax, obliterating the costophrenic angles. It gradually shades off above and medially into normal lung shadow. In massive effusion, no lung shadow is visible. There is shifting of mediastinum to the opposite side. Simply, there is fluid collection in the pleura, it is pushing the lung. And mediastinal, in case of massive effusion, there will be mediastinal push to the opposite side. Okay? সাদা মানেই ডেন্স হোমোজেনাস। ওই টেক্সচার দেখো তুমি, মানে কল ইট ডেন্স হোমোজেনিয়াস ওপাসিটি। So what are you seeing? Who will describe? কে describe করবে? ওকে বলি, তুই কর। বল বল। পরীক্ষার সময় you will have to speak, otherwise you won't get marks. Skyogram of the of the chest. Okay, thorax is okay. Okay, then there is a dense homogeneous opacity in the right. কোন zones গুলো বল? Middle and lower zone of the lung. Comment on the costophrenic angle, right costophrenic angle. There is obliteration of the right costophrenic angle. Okay, and there is a actually there is a dense homogeneous opacity in the right, middle and the lower zone of the lung, and there is also obliteration of the right costophrenic angle. Most probably it is pleural effusion. Okay, now is there any mediastinal shift? Slight. Good. Okay, কারোর কোনো কোয়েশ্চেন এই প্লেটটায়? এই যে এইটা দেখ, এইটা কস্টোফ্রেনিক অ্যাঙ্গেল। লাংস আর ডায়াফ্রামের মাঝখানে একটা অ্যাঙ্গেল, বুঝলি? এই যে এইটা, ঠিক আছে? আরেকটা অ্যাঙ্গেল আছে কার্ডিওফ্রেনিক, ওটা কার্ডিয়াক এক্সরের সময় পড়াবো, ঠিক আছে? Now we will talk about the hydro or the pneumothorax. So what happens? In erect posture, homogeneous dense opacity with obliteration of costophrenic angles at the lower part of the hemothorax due to fluid or pus. It is nothing but collection of pus or fluid and also air in the pleural cavity. Both are there. Translucency due to air without any lung marking above the opacity with a horizontal fluid level in between. So এরকম একটা fluid level আছে, উপরে there is air, নিচে there is fluid. তো উপরে কোনো lung marking নেই, ঠিক আছে? বাট প্লুরাল এফিউশনে কি হচ্ছিল? উপরে লাং মার্কিং ছিল আর নিচে ফ্লুইড ছিল। এখানে উপরে কালো, যেটায় কোনো লাং মার্কিং নেই, আর নিচে জল। হ্যাঁ হ্যাঁ, এয়ার ফ্লুইড ইন্টারফেস। And there will be mediastinum shifting to opposite side. A collapsed lung with globular opacity at the hilum may be visible if it is not obscured by the fluid and the opacity. Background ওটা দেখতে পাওয়া যায়। এই দেখ, horizontal air fluid level, বুঝতে পারছো? এইটা কোলাপস লাং এর বর্ডারটা, এইটা এয়ার, এইটা ফ্লুইড, আর এইটা লাংটা কোলাপস হয়েছে, বর্ডারটা দেখতে পাচ্ছ? ক্লিয়ার? আরেকবার সো this is the fluid level, the horizontal level. এইটা হচ্ছে লাং, এটা হচ্ছে কোলাপস। এটা দেখো কেমন একটা ব্রঙ্কোভাস্কুলার মার্কিংস গুলো কেমন একটা ক্রাউডেড হয়ে গেছে এই জায়গাটা হাইলামের কাছে, as well as the lung border is looking this, actually this is the medial border of the scapula, this one, and this portion is the collapsed area, and এই যে এই সাইডে দেখছো এটা হাওয়া, অল্পই আছে তো হাওয়া আছে, and this is the level of the fluid. So since there is amount of air above the fluid, we are calling it hydropneumothorax. এইটা অনেকের গুলিয়ে যেতে পারে, কেউ অ্যাবসেসও বলে দিতে পারে এয়ার ফ্লুইড লেভেল আছে বলে, বাট অ্যাবসেস কেন বলবো না, কারণ আমি হচ্ছে লাং মার্কিংটা কিছু পোর্শনে দেখতে পাচ্ছি না। অ্যাবসেসটা লাং এর ভিতরে থাকে, চারিদিকে লাং থাকবে, মধ্যখানে অ্যাবসেস থাকবে। ম্যাসিভ, in massive cases only abscess will be visible, but abscess is a cavity inside the lung na, surrounding area is lung, and in the middle you are getting a cavity where there is air fluid level. Again in pneumatocoel also same thing, surrounding lung মধ্যখানে you are getting a cavity with an air fluid level. How will you differentiate abscess and pneumatocoel? Abscess has a thick wall and pneumatocoel has a thin wall. But this is something massive, and particularly this horizontal marking from starting from the heart up to the chest wall is found in case of hydropneumothorax. ठीक है, clear? ठीक है. But when this is an erect posture, when we are doing supine or prone, you won't get the horizontal fluid level. It is getting displaced. ठीक? Okay. So in that case, you will get ground glass opacity homogeneous involving the affected hemithorax, but you won't get any fluid level. In that case, you will get that collapsed lung and air, but not the fluid level. Okay, and mediastinal shift will be found to the opposite side. You will be given simpler X-rays only, which you will be able to identify. So this is some common chest X-ray findings and indicative diagnosis I have written everything on the slides from bedside clinic by Dr. Shivarjan Ghosh. Nothing from outside any, I haven't mentioned anything from any other book. This is totally given in bedside clinics by Dr. Shivarjan Ghosh. This table is also found there, but I will try to explain the table to you. So let's see. Suppose in the X-ray you are getting perivascular and peribronchial cuffing or prominent bronchovascular markings. What are the conditions? If it is diffuse bilateral, it is due to early pulmonary edema or acute bronchiolitis. If it is localized to any lobe or lobes, it is due to localized infection like bronchitis or early stage of bronchopneumonia. Okay. Suppose you are getting interstitial infiltrates with peribronchial and perivascular cuffing. What do you mean by cuffing? Suppose this is the bronchus and surrounding area you are getting infiltrates. Perivascular, peribronchial. মানে একটা structure, তার চারিদিকে তুমি হচ্ছে infiltrate. So peri means the perimeter. ঠিক আছে? So this is localized to one lobe, aspiration pneumonia, early tuberculosis. Diffuse bilateral with hyperinflation of the lungs in viral pneumonia, atypical pneumonia by mycoplasma pneumonia. If you get multiple patchy opacities with hyperinflation of both lungs found in bronchiolitis, if you get hyperinflation of both lungs and granular opacities in between giving a coarse mottled appearance found in bronchopneumonia. If you get coarse mottled appearance only in one lung, it is unilateral bronchopneumonia. If you are getting alveolar infiltrates and granular opacities, very difficult to differentiate alveolar infiltrates. Just comment about infiltrates. You will be able to, what I have taught you, dense homogeneous opacity, it is lobar. But when you are getting patches of opacity, it is only bronchopneumonia or viral pneumonia. If you are getting hyperinflation and patchy opacities, it is bronchiolitis. Yes, these are the different conditions we get in pediatrics. After you start seeing the X-rays repeatedly, you will be able to appreciate, oh, this is, I can see hyperinflation. Why I am calling it hyperinflation? Because I am counting the anterior end of the ribs. If on the anterior side we are getting more than 8 rib count or more than 6 rib count, we will call it hyperinflation. Lungs are big, intercostal spaces are wide, costophrenic angle is wide, flattening of the diaphragm, lung fields are big, there is air trapping. But along with it, we are getting perihilar patchy opacities. We call it bronchiolitis. But if the opacities are more, we call it viral pneumonia. Okay. Bronchiolitis ke kore, respiratory syncytial virus. Okay. Then mycoplasma pneumonia causes atypical pneumonia. You won't see it as lobar consolidation usually. It can present as atypical findings also. Okay. Then if you get, what will you get in fibrosis? Fibrosis you can get in TB patients. You can see these X-rays in the medicine department. In the adult patients, you can get fibrosis over any part of lung. Fibrosis ke kemon kore describe kore? Coarse, dense, streaky opacities. Okay. Now in bronchiectasis, what is the condition? There is crowded and dilated bronchi in an opaque background due to fibrosis or exudation, giving a honeycomb appearance. Pathology te podechile honeycomb appearance. But X-ray finding take ki kore describe korbo? Coarse, dense opacities with crowding of the bronchi, usually localized to one or more lobes. Now, what do you find in miliary tuberculosis? Bilateral finding, diffuse, evenly distributed, small, dense and well-defined opacities like millet seeds. Okay. Diffuse, evenly distributed, small and ill-defined opacities giving a snowstorm pattern. These are the classical terms. Okay. Found in acute miliary tuberculosis. Chronic miliary ke bolche millet seeds, acute miliary ke bolche snowstorm. Now, in progressive primary tuberculosis in a concentric manner or radiating manner, you will get spreading opacities from a primary pulmonary focus with associated hilar lymph node shadows. So, tell me, in a patient who is suffering from tuberculosis, what are the suggestive findings in X-ray? এখানে অনেক ভারী ভারী টার্মস ডিসক্রাইব করা হয়েছে। Simply, you are suspecting pulmonary tuberculosis. What are the X-ray findings which are very suggestive of pulmonary tuberculosis? দুটো তিনটে জিনিস বলতে হবে। Hilar lymphadenopathy, number 1. Number 2, miliary shadows. Okay? So, এই দুটো জিনিস, when I am in an OPD, I am taking history, there is chronic cough cold, the child is having this chronic cough cold, low grade fever for more than 2 months, 1 month, 2 months, and the child is not gaining weight. There is a tuberculosis patient at home, means contact history is positive, and I just ask the mother to please get a chest X-ray done. And when I am seeing the chest X-ray, oh, there is the hilar lymph nodes appear to be large, and yes, I am seeing some opacities, some small opacities over the lung field. My first suspicion will be, oh, this X-ray is suggestive. Then I will order a gastric lavage CBNAT or a sputum test to see acid fast bacilli, or I will do a CBNAT test where I will try to find out the nucleic acid material of the Mycobacterium tuberculosis.